Good afternoon, ladies and gentlemen. My name is Gary T, and I'm very pleased to be talking to you about our work on Brugada syndrome today at the Imperial College London Clinical Genetic Society's annual conference. So I was very pleasantly surprised that Justina from your society got in touch with me several weeks ago to give a talk at the society. So I myself only graduated from Imperial College around 7 years ago. I don't recall having a clinical genetics society back then. And it's really, clinical genetics is becoming very important in our day-to-day research work as well. So without further ado, I'm going to talk about the work that we've been doing, in particular on genetic basis and also risk stratification of Brugada syndrome. And most of the materials that I'm going to talk to you about came from the collaborative work done in Hong Kong, and we will also show a few slides on the possible collaborations internationally. So the plan of today is to firstly provide an overview on the background on the genetic basis of Brugada syndrome using the findings from our Hong Kong cohort. Secondly, it is to review the risk stratification strategies and multi-parametric scores available for Brugada syndrome. And finally, I would like to outline the opportunities for international collaborations. So in terms of cardiac ion channelopathies, these are used to describe a set of inherited or acquired conditions that are due to dysfunction in the ion channel proteins or their associated subunits, often in the presence of structurally normal hearts. So all of these conditions are associated with the development of ventricular tachyarrhythmias and sudden cardiac death. And at the basic level, they can be attributed to abnormalities in action potential depolarization, repolarization, or action potential conduction. So here are listed the four commonest ion channelopathies. So Brugada syndrome, as we're going to spend a lot of time talking about today, but ion channelopathies also include long QT syndrome, catecholamiine polymorphic VT, and also short QT syndrome. So just want to say a few words about genetic testing. So I'm not a geneticist, but I think it's quite important to recognize the limitations and the power of genetic testing. So genetic tests are probabilistic, they're not deterministic. So around 4% of Caucasian and up to 8% of non-Caucasian subjects host rare, non-synonymous genetic variants in genes that encode for the cardiac ion channel proteins. So one of the efforts really needs to distinguish between the background noise and true pathogenic mutations. And often the yield of genetic testing correlates strongly with the phenotypic strength. So for example, if it's idiopathic VTBF, then the yield is generally lower, whereas if you have a confirmed diagnosis, the yield tends to be a little bit higher. And what we can do is we can use algorithms based on location mutations to estimate the probability of pathogenicity of each mutation identified. And also, there is also a substantial role for functional studies to look at the ion channel electrophysiology. So in terms of Brugada syndrome as an inherited ion channelopathy that's associated with VTBF and SCD, so there is a characteristic coved or saddle-shaped ST segment elevation in the right precaudal lead, as you can see here, so V1 and V2. So the main problem for clinicians is that patients with these patterns or with the Brugada syndrome are at various risks of adverse events. And risk stratification is actually quite difficult, as I'll show you some of the data that we produce a little bit later on, especially in the intermediate risk subgroup. So there are certain high risk features that we already recognize. So patients that have previous presentations of VTBF or aborted sudden cardiac death, or those with a spontaneous type 1 Brugada pattern, of particular high risk. So, whereas low risk patients, they generally have no symptoms such as syncope or no evidence of previous cardiac arrest, or if they have a type 2 Brugada pattern. But really the difficulty is what happens when the patient comes in with a mixture of high risk or low risk features, or that it might be that some of the high risk features have not developed yet. So we took use of the local data and we made use of the opportunity because the disease prevalence is higher in Asia. There is also very good electronic health record linkage in the public hospitals. For example, if a patient comes into hospital 1 with Brugada syndrome and subsequently gets discharged and then represents at a different hospital, as long as it's in the public sector, then the attendance and the health records can be retrieved and analyzed. So there's little missing data. And there was also great potential impact from multidisciplinary collaborations, not only for medicine, but also with engineering and data science colleagues. So what happens around year 2000 was that it was still a relatively unrecognized disease in Hong Kong. With a population of 7 million, of which 95% of the Chinese, Brugada syndrome is virtually unknown before 1999. And here, one of our colleagues, Dr. Mock, estimated that given that these regional hospitals serve a population around 2.5 million, and that the prevalence is around 2 per 100,000 adult population, then it means that there are a lot of cases that were undiagnosed at that point, or at least unrecognized and not picked up by the physicians. So what's happened 20 years later? So the data from our group managed to identify around 545 Brugada patients. So only around 10% underwent genetic testing, and of those 10% that were tested, the yield was around 34%. So it's actually quite similar to the published values of around 20 to 30% in the literature. What we managed to find was also 6 novel SCN5A variants. So in terms of the mutations identified, we found several mutations that were described by other studies already in the literature, and we also found around 6 new variants that were potentially pathogenic. So in terms of the case presentations, not all of the patients actually came in with VT-VF. So some had low risk features. For example, they didn't have any syncope and they didn't have any VT-VF events, whereas others, such as this patient here, there were multiple syncope episodes, and the patient was also positive for provocative drug testing. And then if you look at another case here, the 4th case, the patient actually had prior VT-VF, so there is a mixture of differing risk levels, despite all these patients being positive for the SCN5A mutations. So in terms of clinical details, so I won't go into describing every single case, but essentially with the functional studies or animal models, some of the mutations have had electrophysiological correlates. So for example, this ALT225Q mutation showed a prolonged PR interval, so atrial ventricular conduction block in mice, and there was also explained by a reduction in the peak sodium current density. So in this example, so A1427S, the functional study is actually ongoing by our team looking at stem cell-derived cardiomyocyte models. So it really illustrates the importance of correlating clinical findings with functional studies. So in terms of what these where these mutations are, so if you remember the basic physiology, so the S4 is the voltage sensing domain. So so if you have mutations that affect the protein sequence around the S4 region, then you're going to affect the voltage gating characteristic of the ion channel. So the activation, inactivation, and recovery from inactivation characteristics of the ion channel. There is also some evidence to suggest that if you disrupt the link region between S5 and S6, and you disrupt also the C-terminus aspect of the gene, then you do also get some sort of functional impairment in the SCN5A channel. So in terms of recent advances, in collaboration with other teams, we also looked at the SCN5A variant in not only Brugada syndrome, but also early polarization syndrome. And we found that SCN5A is also a major susceptibility gene in ERS. And we did also find a case of fever-induced early repolarization pattern. So fever-induced Brugada pattern is quite a well-recognized feature, which is why we try to tell patients that to avoid fever and definitely take antibiotics. And we also found temperature-dependent phenotype in early repolarization syndrome. So there may well be overlapping features between these two conditions. So in terms of fever and SCN5A mutations, you can see that in this patient here, the patient originally presented with fever. You can see that there's very marked ST segment elevation in lead B2, but as the temperature subsided, the ST segment elevation gradually resolves. So we also performed further risk stratification based on SCN5A status, and we found that those had positive SCN5A mutations tended to be diagnosed earlier in their lives. We also stratified the age of diagnosis between those with adverse events and those without adverse events, and we also found that there was also a younger age tendency for Caucasian subjects to be diagnosed earlier than Asian subjects. In terms of risk stratification, so hopefully the next several slides I'll show you illustrate the difficulties in accurately stratifying the risk of arrhythmic events. So this is the current guideline for primary prevention, so i.e. for patients who have never experienced VTVF events. So it's currently based on the presence or absence of syncope of cardiac or arrhythmic origin. So if you've got prior syncope, then there's a class 2A indication for ICD implantation. Whereas if you're asymptomatic, but if you have a spontaneous type 1 pattern, then the guidelines suggest that we assess for other risk markers. So for example, the presence of conduction disease, the presence of bradycardic complications, electrocardiographic abnormalities. So these often reflect abnormalities in depolarization and repolarization, SCN5A, so genetic phenotype, and also the family history. And currently, programmed ventricular stimulation is also suggested as a consideration for further risk stratification. So if there is a positive propagation test by programmed electrical stimulation, then it's a class 2B indication. Whereas if it's negative, then the guidelines recommend close follow-up. So in terms of who should receive an ICD, so this slide just illustrates there are regional differences in recommendations. So for example, in the expert consensus statement, inducible VF on EPS is a class 2B recommendation, whereas in the Japanese guidelines, if you've got type 1 pattern with any of the other features listed here as a class 2B, so we do need to be mindful of the guidelines as well. So in terms of symptoms, so presence of syncope is associated with fourfold increase in the arrhythmic risk, but not all types of syncopes is the same. Neurally mediated syncopes generally considered to be more benign than those of cardiac origin. So we do need very detailed clinical history surrounding the clinical scenario. So any prodromal symptoms, any precipitators, any witness and patient's accounts. And there is a possible for more intense rhythm monitoring using implantable loop recorders. So the asymptomatic cohort is also problematic. So they're previously thought to be low risk of sudden cardiac death, but over a 10-year period, so 7% of these patients actually have been shown to suffer arrhythmic events as defined by the appropriate ICD shocks. So with this meta-analysis here of around 13 or 1,400 patients, you can see that patients with suspected arrhythmic syncope have the highest rate of adverse events. But if it's less defined, so suspected arrhythmic but undefined, is generally lower risk. If they're thought to be of non-arrhythmic origin, it's still not a zero risk, so there is still a risk of 0.2 events per 100 person years. So in terms of ECG patterns, spontaneous type 1 patterns associated with high risk of future arrhythmic events compared to drug-induced type 1 pattern. There is also some diagnostic difficulty and also sensitivity in the placement of ECG leads. So if you place them higher up in the intercostal spaces, then it increases the pickup rate of detecting a spontaneous type 1 pattern. And we also have combination risk factors. So for example, here we have spontaneous type 1 with cardiac syncope is high risk. All about spontaneous type 1 with asymptomatic is a completely zero risk. And also we have a patient with drug-induced type 1 pattern. So we have to ask the question, are they always low risk? So this slide pretty much answers that question. So here it shows the drug-induced type 1 pattern for patients with presenting aborted cardiac arrest. So you can see that in the Italian cohort presented here, 11 patients had an initial drug-induced type 1, and same for the BRUGADA and other cohorts where drug-induced type 1 pattern might be the initial presentation for patients with an aborted SCD. So this might not always be a low risk marker. So there's also some debate on the prognostic implications of programmed ventricular stimulation, and this really boils down to the patient selection criteria and also how aggressive your provocation protocol is. So the protocol, so for example, the number of stimuli delivered. So these are some of the other risk markers that can be detected in the ECG. So here is the positive R wave sign, so this is a depolarization marker. Here, early repolarization pattern peripheral leads. That's also a high risk marker. S is a significant S wave in lead V1. The presence of fragmented QRS, which represents a dispersion in conduction throughout the ventricular myocardium, and also prolonged QRS duration reflecting slowed ventricular conduction, and also prolonged QTC and prolonged TPT and intervals reflecting increased dispersion of repolarization. So in terms of clinical risk scores for risk stratification, so we tend to lump together the patients who are at intermediate risk, but these patients are not all the same. There's also a problem of intermediate risk patients with varying levels of risk. So there is some help by the development risk scores. So there are a number of predictive risk models or risk scores proposed by various investigators, but not many have been externally validated. So these are the major scores that I could find, and they've all been listed here. So the number of patients used for model developments showed in the second row here. So you can see that a lot of the cohorts are not that big, and they do lack external validation, which is why in these studies, so my colleague Sharon Lee here, we used one of the largest cohorts in the Asian population to validate some of this risk scores. And so you can see that there is a great disparity in the variables selected for inclusion in the risk model. So this illustrates one example. So this is a risk score that came from the UCL group, and essentially they picked up spontaneous type 1 Brugada pattern, prior history of syncope, and also type 1 ECG, and also early repolarization pattern in peripheral leads. And they show that as the risk score increased, the 5-year predicted risk of ETVF also increased. So this is the study from our collaborator based in Wuhan, China, and also the USA, where we demonstrate that if we have age, ethnicity, family history, and TPT and interval, the area under the curve is around 0.89, so pretty good predictive value. So in terms of what we've contributed to the literature, so we have worked on the genetic basis Brugada syndrome, and we've used a multi-parametric approach to improve risk stratification. We also demonstrated that serial ECG testing, so obtaining multiple ECGs across different visits, can be helpful in providing further risk stratification values, as a higher temporal variability in ECG markers can be associated with higher arrhythmic risk. We also found that the VF risk differed significantly between pediatric, young, or adult presenters, so the age of presentation might be important as well. And we also showed that the risk prediction can be enhanced by the analysis of automated ECG data, followed by the application of machine learning methodologies. So in terms of multi-parametric risk scores using local home data, we initially analyzed around 516 patients. We showed that based on this initial presentation, so asymptomatic syncope and VTVF, there is a progressively increase in the arrhythmic risk, as shown in the survival curve here. And we also identified some significant predictors. Most notable is the QTC interval. So what we did was we took the data and took one step further in analyzing the predictive value for the published scores. So we expanded the cohort to around 548 patients, and then around 12% of these patients had one episode of sustained VTVF during follow-up. So these are all of the significant predictors on Cox regression. So univariable Cox regression, we found that a change in Brugada pattern, so i.e. Patients that flip between type 1 and type 2 patterns, the presence of syncope and initial VTVF on presentation. But we also found that the presence of other arrhythmias is also important, and these include atrial flutter fibrillation, SVT, and also sinus node dysfunction. We also found that early repolarization pattern in the peripheral leads, AVR sign, significant S wave in lead 1, and QTC interval were also predictive, and some of these factors remain significant on multivariable analysis. In terms of the existing risk scores, so this further details on the various published scores, and what we did was we used our data set and validated the performance of these scores. So you can see here, actually, out of all the scores, only the score produced by Sierra and colleagues showed a good predictive value of around 0.81, whereas the remaining scores, they didn't perform so well on external validation. And when we looked at these published scores, we were able to pick the best one and then further develop the score by including extra variables that we found that were significant on univariable Cox regression. So these were the presence of other arrhythmias, early repolarization pattern, ABL sign, S-wave in lead one, also prolonged QTC interval beyond the full 36 millisecond cutoff point. So in terms of performance, you can see here, so these are receiver operating characteristic curves. So the top left panel shows the AUC for our score, which is the highest with an AUC of around 0.85, followed by the Sierra score, which is pretty good at 0.80. And the women scores didn't perform so well. And you remember what I said earlier about those patients who are at intermediate risk? They're actually most difficult to stratify because they have a mixture of high risk and low risk features generally. And what we found was that when we applied the score only to this intermediate risk subpopulation, the AUCs dropped significantly for all of the scores, including ours. So for example, the AUC dropped from 0.85 to 0.70 for our score, and the Sierra score, it dropped from 0.80 to 0.57. So this really illustrates the difficulty in stratifying the patients who are at intermediate risk of arrhythmic events. So in terms of the future, what we hope to achieve is that we can include genetic variants in the risk models. For example, some genetic variants are more likely to be producing a more severe phenotype than others. So this might be incorporated in the future. And we also hope that the electrophysiological mapping, so the 3D mapping results can be also incorporated into the risk models. So in terms of opportunities for international collaborations, so this really illustrates the power of cooperating with other countries. So we're able to combine several cohorts from Hong Kong, Greece, and Germany to improve upon the previously shown predictive models. So this is my colleague Sharon, who presented recently in Computing in Cardiology, where we looked at the pairwise interacting features to improve risk stratification. So in terms of what colleagues here can contribute to, so I'll definitely invite you all to join our international BRUGADA study. So it started off as a single center study in Hong Kong, which then has rapidly increased to a multi-center study from 43 centers based in 21 countries. So we now have one of the largest BRUGADA syndrome cohorts globally, with around 1,500 cases. So we're very happy to include any number of BRUGADA syndrome and pattern patients, as long as they have some clinical details that can be used for risk and prediction. In conclusions then, ladies and gentlemen, so hopefully I've convinced you that multi-parametric approach is the best approach so far for risk stratification. However, it's not perfect. The most difficult subset to risk stratify is those with low intermediate risk. Because sudden death is actually a very traumatic experience for family members, so even a very low risk might not be acceptable. There are multiple scores that are available for risk stratification, but only a handful have been externally validated, and they tend to be not performing very well with an external cohort. So there is definitely a role for machine learning algorithms to improve the predictive value of the existing scores. So I just want to leave you with a few thoughts. So what is BRUGADA syndrome? So there are various definitions of BRUGADA syndrome, and really some of the case definitions depend depending on which diagnostic criteria you use. What about low-risk patients? Should they or should they not receive an ICD? What is an acceptable risk to bear for not intervening? Bear in mind that having ICDs is also a risk for the patients. For example, there are inappropriate ICD shots. There can be infections in the pocket, so we can't just routinely give an ICD to every single patient. Just want to acknowledge the colleagues who have invited me to give this presentation at the Genetic Society, and also all of the work that's been described in this presentation is collaborative. So they have been performed by not only myself, but also team members, Sharon Drandon, who's a data scientist, looking at improving the models using machine learning, and also local and international collaborators. So I would like to thank you all for your attention.